right, perfect. So yeah, I'm Craig Vandervelden. I'm from Children's Mercy, Kansas City. And today I'll be talking about some work we did for developing a population health dashboard for performing diabetes self-management habits. So the motivation really came with when we saw that population health dashboards were able to help improve T1D outcomes. And it started when we saw Stanford's TIDE dashboard, which is an algorithm-enabled population health dashboard for T1D patients. And it showed different risk categories based on CGM metrics and prioritized patient outreach based on those. And they were able to see both improved time in range as well as reduced provider time spent per patient, which helped lead to increased clinic capacity. So when we saw Joyce Lee's paper about the 6 habits, we thought this would be a perfect opportunity to make a population health dashboard for this. So these are 6 self-management habits, and performance of each were associated with both improved HbA1c as well as time in range. And the 6 habits are if they check their blood glucose levels over 4 times a day, or if they use a CGM, whether they give 3 rapid-acting boluses per day, if they use an insulin pump, if they deliver boluses before meals, if they've reviewed their glucose data for patterns since their last clinic visit, and then also if they changed their insulin dosage at least once since their last clinic visit. And this column here is just showing how we're getting the data, which is a mix of device data or data from the electronic medical record. And for a few of them, we also have a bit of priority for which one to choose if both are present. So our objective was to create an interactive population health management tool that displays data related to these 6 habits for providers. And then we also wanted to incorporate new habits which align with the 7 pillars of diabetes self-management. And to that end, we also added the 7th habit, whether they consume a healthy diet, which is just a self-reported question stored in the electronic medical record. And just for a bit of background, the population is all of our patients that had a clinic visit from the first of the year in 2021 up to present day. And what really enabled us to rapidly create this was our diabetes data doc, which Brent will be talking about in the next presentation. And I'll just very briefly go over it. The way that it works is we ingest data from a variety of sources, the electronic health records, device data, REDCap, in a variety of formats, and this maps them all to a common schema. So we then have a cloud data pipeline which both stores the data, and then we have processes to clean and validate, extract, transform, load, perform mapping, do machine learning, and create visualizations. And then we have a serving layer which both displays our interactive dashboards, helps support our quality improvement team as well as research, such as remote patient monitoring, and then also display the results of our predictive machine learning models. And the key focus of this diabetes data doc is we want to build reusable processes. And one of the benefits was we already had all of the data present on the 6 habits, and it refreshes weekly. All we really had to do was alter our extract, transform, and load process to set rules on how do we want to count habit performance, such as how far do we look back, which data source do we use, and what happens if we have multiple results. So we're able to very quickly make a table that has information on the 6 habits and then create an interactive dashboard in under a month. So I'll now go into the results of what this dashboard looks like. It's a Power BI dashboard that's available to all of our providers. And here what we're showing is habit performance. So the orange bar shows counts of people not performing a habit. The blue bar shows people that are performing a habit. And we're able to select what all is shown. We can also, on our end, show where our processes could be improved with this data unavailable, which is this gold bar. So for us, we see we have some work to do on habit 5, whether they review blood glucose data, which we're actively working on. And we're also able to create user-definable populations. So we're able to filter by demographics and covariates like race, insurance class, age, also by date ranges, whether it was their latest visit. And these were things that we just that were important to us, but we also have a lot of other covariates that we could filter by. So we can also see how habit performance associates with different glycemic outcomes. So this is showing the same performing and not performing and how it associates with average HbA1c. So the way that I like to think of this is how much bang for your buck do you get for performing each habit? So you can see for people that use that monitor their blood glucose levels, either with a CGM or finger sticks, on average, their HbA1c is 1.5% lower compared to people that aren't effectively monitoring. And then we also see similar trends for time in range for CGM users. And then also we can see how someone's habit score, and this is the sum of all of the habits they're following. It doesn't matter which combination. So someone with a habit score of 2 follows any of the 2 habits. And we can see that generally people that have a higher habit score have lower mean A1Cs. And we also saw a similar trend with time in range as well, just the inverse where it's higher. And of course, we're still able to filter by all of these demographics to analyze different segments of our population. So I'd also talked a little bit about proposing new habits that map to the 7 pillars of diabetes self-care. So most of the 6 habits are related to either monitoring or taking medication. And we've currently added our 7th habit, which is a healthy diet. And we're actively working on an 8th habit, which is if they partake in an active lifestyle. So to conclude, the 6 habits dashboard gives us a population level view for habit performance of our diabetes center. We saw that habit performance and habit score is both strongly associated with glycemic outcomes, A1C and time in range. And then the dashboard also shows which habits lead to the largest change in glycemic outcomes on average. So for future work, we're looking at creating individual level habit performance. So something maybe like looking at someone's HbA1c versus their total habit score, where we can search by MRN and then get demographics for them. And we're also looking at creating or matching interventions based on habit non-performance. So for example, if we have a person, we can see which habits they are performing, which habits they're not performing, and a list of current interventions they're on. And then our aim is to develop a recommendation algorithm, which will recommend interventions both ranked by impact of glycemic outcomes, as well as the burden that that habit might have, because some habits might be much easier for someone to adopt than other habits. So with that, I'd like to thank everyone involved in this work, our funding resources, as well as the Rising Tide Alliance, and I'll be open for any questions. Thank you.
Thank you, Craig. Any questions from the audience for Craig?
I may have missed this at the very beginning, but how those 6 plus 7 habits are assessed? Is it like at a clinic visit? Is it like a flow sheet? Is it some sort of my chart? How do you actually capture those 7 habits?
Yeah, so it's a mix of data that we get from the electronic health record, which all of that data comes from a clinic visit that gets charted. And then some of them, such as like CGM metrics, we try to get those from device data, which will be shared with us automatically.
Some sort of flow sheet integration, or I guess, how do you capture that from device data? Is it like glucose flow sheet, type pool? How do you actually capture that?
We use a power form to capture that data. And for device data, that comes from our data doc, which we have APIs to connect to. And Britt will probably talk a bit more about that as well.
So it can be either way, either physician or clinician documented or direct from devices.
Sorry, there's a question from Lauren about how the device data is shared automatically.
So our device data we get directly from either Gluco or Tidepool, and that comes from our data doc that we just automatically refresh weekly. Brent will talk a bit more about that.
And then is the provider updating their note each time or a flow sheet? How's this info getting into the EMR?
So this gets updated each time they have a clinic visit, and then they'll be asked questions related to these, and then it's updated then.
You basically identify some risk factors here, right? 1 through 6. Did you compare with some other possible risk factors, for example, for poor control, which could be age, zip code, socioeconomic status?
Yeah, I think that could be an interesting thing to look at. We have been doing a lot of work with geocoding to calculate various indices that map to socioeconomic status. And it could be interesting to look at how different population segments compare with that. One of the other covariates we have is insurance class, which also associates with socioeconomic status. So we could make comparisons that way as well.
Thank you, Craig. Just to verify, are in-person or our virtual attendees hearing the in-person conference attendees questions? Just want to verify.
If you could repeat that.
We'll repeat it. Okay. All right, thank you. Great. So we're going to move on to our second presentation by Brent Lockey, who will be talking about the creation of a diabetes data doc to integrate, improve, and analyze diverse data sources and facilitate continuous learning and improvement.
Okay, great. So got things switched over and I will share. And I just want to know while I'm getting set up here, am I on a big TV screen in the room? Yes, okay, good. I feel like the kid from Willy Wonka when that happens. Like I'm just living his dream. And I just wanted to acknowledge that now. So everyone's able to see the presentation, I take it. So we're talking about the creation of a diabetes data doc to integrate, improve, and analyze diverse data sources and facilitate continuous learning and improvement. So it facilitates things like the dashboard that Craig just spoke about. And I think it solves some really thorny challenges that I think almost all diabetes centers have to deal with. There we go. No conflicts to disclose or anything. So I want to speak about what our situation looked like before we started this data doc work. And in talking to other folks, I think this is a very common situation. Members of the T1D exchange have diverse goals, and they want to do things like risk-based population health management, but there are data integration and management challenges that are quite persistent. So in this diagram, we've got a couple data sources on the left, the medical record, a few device vendors, and maybe a survey and intake tool that people use to manage intake. And then you've got the diverse goals on the right. And each time you want to do something new on the right side and bring in some new functionality, things more or less start at zero, back at all the data sources, and you're wiring them up to get the specific output that you want. And each one of these is a single use process and pipeline. And the difficult thing, of course, is that over time, there might be slight differences in these and they become hard to manage. And so I think, in fact, it ends up looking a bit more tangled. So we really aim to design and create a cloud data infrastructure that would be highly reusable in general to support any goals that we might have on the right side and handle the diverse data in a systematic and trustworthy way that really builds trust amongst all the stakeholders. And we call that the diabetes data doc. So that's the approach that we've taken here. And again, it's in order to facilitate all those things we want to do on the right-hand side is really why we're doing this, right? You don't really build infrastructure just to build infrastructure. It's so that we can do these things on the right-hand side more quickly and in a way that builds trust. So I'll go over the technical setup for this. And for folks that are non-technical, I would encourage you to really, and I'll try to emphasize this, we're looking at several different functionalities here. And I think those are the most important things. So with all this data, right, one of the first things we need to do is store it, right? So it comes in a variety of sources, sometimes via flat files, sometimes via API connections to device vendors. It comes out through Cerner Healthy Intent for our EHR. And so each of these are a little bit different. We need a common area to store it. And for that, we use Azure data lakes. Those are just, you can think of as big file storage systems. And I would zoom out a little bit here and just say that the tools you're going to see are primarily Microsoft Azure cloud-based tools. That's the setup that we went with here. So you've got to store things first, and we use data lakes to do that. The nice thing about that is it allows us to store any data in the format that it comes to us. We just save the incoming raw files. So once you've got data stored, you need to do something with it, and that's our compute functionality. So we use Azure Databricks to do that. And for those that code, it looks as an interface very similar to Jupyter notebooks. So that's very commonly used in research to build up scripts and transformations of data in a user-friendly type of way. So it looks like that and allows us to build and code repeatable processes. It's also highly scalable. So we can really ramp up or ramp down our computing power as needed. And the way that it works is it mounts to the storage, reads data from the data lake, and then writes data back so that the storage is always in this data lake environment. And we also here have a data orchestration layer. As we build up step-by-step transformations, we really need, effectively like a scheduling and task automation piece, and that's what Data Factory is. It provides a nice visual output so we can understand our processes at a glance. After compute, we've got to serve it, which is really just make it available. So we use Azure Synapse to do that. We use that in order to balance cost and availability. I'll just say it seemed like a nice way to make things available, but not be running up a big cloud bill for us. And then for the most part, when it comes to publishing and using data, we primarily use Power BI to build visualizations and make them available for the quality improvement team, diabetes nurse educators, and other clinicians. So this is the overall structure here. And I'll just, while I'm on this spot, since there was a question asked to Craig about this, for device data, for these vendors here, Clarity, CareLink, LibreView, and T-Connect, we get that data via flat files. So we do exports from our hospital account, like bulk exports, and then we put the raw files in the data lake. For Gluco and Tidepool, we're connected to their API. So we get them more programmatically and much smaller incremental updates in those cases. So I think that covers the technical part of it. And I just wanted to point out a few things here. Data has common challenges around volume, variety, and velocity. And those are really handled with the Microsoft cloud-based tools. It can scale up and down. It's really flexible. It's really built to solve these problems. I want to talk a little bit about veracity. People that work with data are always saying that the data is dirty, and that's always a challenge. For us, we overcome that with a multi-hop architecture. And at any of those steps, we can insert data validation. So really what that looks like is we save the raw files in the data lake. We minimally process it, basically save it as is, but save it as a Delta table. And then we take another small step to, particularly in the case of device data, map it to a common schema so that we can use it. And then we build reporting tables off that. So those steps we can trace back and we can insert validation in any one of these. And so the data doc is up and running. It's ready as well for other centers to potentially implement. And it's in the middle here, helping to, create, for example, our output to the T1D exchange, as well as our risk-based initiatives and operational reporting. Craig showed one of the examples that we've stood up, things we're doing with it. We have internal dashboards to help us visualize our T1D exchange metrics. And the mapping also happens in this environment, I'll say. The 6 habits dashboard that you just saw here, and it's, again, interactive for people to use. And we also have an implementation of the Stanford Tide dashboard for continuous glucose monitoring. So in conclusion, it's replicable, scalable, and we believe ready for adoption at other centers. And we're still exploring the options there. I would just say we have 3 main options, and we want to kind of meet people where they're at as far as allowing for flexibility while also not putting too much technical burden on people. And in some cases, we may kind of let you manage it all, may have a hybrid approach where you kind of own and actively manage the data storage while we more actively manage the other pieces, or something that might be more completely managed by our team in an active capacity, and we would just provide kind of standard outputs. So a big thank you to the team, and open for questions.
Any questions for Brent? Brent, I have a couple questions for you as a fellow Cerner site looking at exactly what you guys have entailed. My first question would be, in terms of timeline, how long did this take you guys to develop this wonderful dashboard that you guys have? The second one is, for all these other sites that are looking to do something, what would be some of the first steps? And I guess the third is, how do we get a Craig and Brent into our institutions?
So we tried to, I think I'm going to take things in reverse order because, yeah, people have short memories, including myself. And you might have to remind me of some of the questions. So first question was, how do we get a Craig and Brent in our institution? And I would say we've designed this to be as portable as we could make it. That's why we built it in the cloud. You know, the software, the code base is maintained in GitHub, Azure DevOps. And so we want it to be something that's portable, because a lot of the work that we did was not so glamorous, right? Like mapping data sources and stuff. Not everybody in the T1D exchange needs to do that over and over again a dozen times. So that's definitely a motivation there. And like I said, we're exploring options that will be a mix, again, balancing like flexibility and technical burden on the people that might be implementing. Yeah, like I said, I think I might have forgotten. But so you asked about like the timeline for a Cerner shop. It's hard to say, because the timeline to build it was like approximately a year. That's not what it would take for somebody to implement it, not even close, because there's so much just design time in there, right? I think in the end, and hopefully this comes across, that it's somewhat simple, which I think is a good thing, a strength. But when you're going through and design it, it's like you have so many options. You could go so many different directions. And so we did have some things that we discarded. And I would say, from a Cerner perspective, we at first had set things up to be consuming the Cerner data, our health data, through business objects exports. That was not very stable or reliable. And so we switched to using healthy intent exports, which, for the flaws of that system, it's more stable when it comes to refreshing and syndicating data. And then for other centers, your second question was about, how could other centers get this going, or what's the first thing that they can do? And I think I'll focus on 2 parts of that. I think the very quickest thing for another center to set up would be something that is mostly or wholly dependent only on the device data, because the schema of that's not going to change center to center. You're going to, unless you're using a device vendor that we aren't, which I don't think is very likely, but is possible. But so the schema is going to be the same, and really it'll be a lot more of a just ready to go, not much remapping that would need to be done, because so that would be the quickest kind of use cases that could be set up at other places. With health data, there would be some remapping that would need to happen, right, as the differences between the systems and things. But I think something that we've done a bit, but could do more in the future, is have the dashboards, visualizations, reports that are relying on electronic medical record data, have that actually be fed by the T1D exchange map schema. In a lot of cases, we could do that. So that would be something that would help accelerate adoption by other places. And then the question would just be, how do we help you manage your mapping from your system to the T1D exchange specification?
A quick question. Well, congratulations for all this amazing work. So let's say if other institutions want to collaborate on that, and you have already explained a little bit what we should do, but what about the data? Where we store our data? Are you going to store it for us? We store, and how does that work with HIPAA?
The question was about data storage for other institutions.
Yes, and so that's a great question and something we're really actively exploring now. I heard Mark, Dr. Clements in the room earlier, so he is a great person to talk to. Like I mentioned, we're exploring three main options there. One where it would be kind of just us handing over the code, and in that case, you'd kind of own everything. And other options where we may be storing or mounting to, storage with identified or de-identified data. So we're just kind of actively working through that with our institution and understanding what is and isn't possible.
I have one more question.
A quick question again on diabetes device data sharing. You mentioned there's sort of two routes for that. The raw files, which I'm imagining is like exporting a CSV file. My question about that is like, who does that? What cadence? I mean, it's at scale if you've got thousands of patients. And then secondly, for the API with glucose and tide pool, is there like a monthly cost to that? I'm just curious about that. So those two pieces of the raw data and then the API sharing.
So the questions were about scaling the raw data and the cost perhaps to the API applications.
Sure. So the cost of glucose and tide pool subscriptions, I don't know the details of. In order to ingest things via the API, I skipped over this a little bit. We use another Azure service called Cosmos Database, which just allows for fast incoming data, and then we kind of copy it from there to our permanent location. The cost is not the cost for that, for the compute and the storage and really everything we're doing. The Datadog is not high. I think it's like a couple $100 a month. It's what we set in Azure. You can have alerts and things for your usage, and we set them at, we felt like a pretty low level. We never get alerts. So it's well within the budget that we established, and is quite low from a cost perspective there. Again, that's outside of what it costs to be connected to those portals, and what they cost separately. And then with the flat files, so with Clarity, and the bulk of our patients use Clarity, it has basically an export all history functionality. So that is really something that every Monday we have somebody on the quality improvement team start, and it can pretty much run on the computer for a couple hours, and then it gets uploaded to the storage account. So that does not take much active work from someone. It takes active work from a computer to like start the bulk download and then upload to the data lake. The other vendors, more typically, you have to export like account by account. So that takes a little bit more active work. And my understanding of the time it takes for that is that the quality improvement team has someone who does that each Monday, and it takes most of Monday to do that for that person. And he does it for people who have had a recent clinic visit, so within the last week or two. So that part of it is not as scalable. Clarity having the bulk export for everybody that's connected is quite scalable from my perspective.
But the cost is pretty equivalent to the cost of setting up an API connection with a lot of device vendors. So it doesn't cost more, which is why we decided to go just with a person until an API connection is available.
Thank you, Brent. So we'll go ahead and move on to our next presenter, Ginny Leverins, who will speak on the role of certified diabetes care and education specialties in development of a 4T program.
So what I really wanted to talk about then is the role of the diabetes educator in implementing this program and how we got it all to work together. It's, you guys can see there's publications out about how the TIDE tool was developed. And there's publications about our pilot project that got the 4T program going. And soon there'll be another publication about our phase 1, because we've completed phase 1 and we're in phase 2. But how did we, okay. So what I wanted to talk about is our role as educators. So youth who were newly diagnosed with type 1 were offered a continuous glucose monitor within the first month of diagnosis. And then the CDE-CES team reviewed the data weekly. And for the pilot kids and for the first phase 1 kids, we reviewed them weekly for the first year. In our pilot project, we had we were sending out messages weekly to every child, whether they needed changes or not. And then as we went into phase 1, we decided, well, we would send them out to our weekly kids if they needed changes, because we were needing to scale it down a little bit to make it more time friendly for us as CDEs, CDCESs. So we did a lot of plan, do, study, act, PDSA cycles to determine the best workflow, to determine what kind of handouts to provide the families. Originally, when we were first started, we would get all kinds, the fellows who do the calls for the new onsets were getting all sorts of phone calls about what to do for technology failure and what to do for this or that. And families, we discovered, were just watching their phones like it was the best TV program around. And so we needed to come up with some handouts and some different ways of teaching. And so we just kept doing iterations until we came up, and we're still doing it, frankly. With iterations of what the best handouts were, and we're now, and what the best workflow is. So, and then we also sent out an anonymous email survey to ask the CDCES team about how they felt their personal experience was in developing this program. So our participant demographics are here. We tried to include everybody. By phase 1, we had enough grant money to include everybody. In our pilot, it was a little more dicey when we were first trying to get started on how we were getting it all approved. But now we can get all of the sensors approved. So we provide them with the first month of sensors. And through our grant money, we are able to buy those and provide the families with the first month of supplies. And then by the end of the first month, we are able to provide those supplies for them. So overall, the CDCES workflow allowed the growth of this program without increasing our CDCES team. So in the beginning, we our pilot study, we saw 135 youth were started on CGM within the first month of diagnosis. We developed a workflow for how we would get them started. We ultimately decided that 1 to 2 weeks after getting started, they needed a CGM follow-up visit. And our nurse practitioners have helped us with that. They do a telehealth CGM follow-up visit 1 to 2 weeks after, just because the learning curve is just so steep. As you all know, who have been involved with new onsets, you teach them a new onset and then 2 or 3 days later, you bring them in and teach them a CGM, and they may have heard this much of what you've taught. So a week later, when they've been week to 2 weeks later, when they have been using the device, then they have all the questions. And then they're like, how do I get another one? And what do I do if it fell off? Those kinds of questions came up. And so our CGM follow-up addresses a lot of that and reminds them we've sent the prescription to the pharmacy, et cetera, et cetera. Through the TIDE tool, we are able to view the tracings and we are able to then decide who needs messages that week. So they're rated in that TIDE tool by percentage of people below 70 and percentage of kids below 54. Those are at the top of our tool. Then the next level down is a real change in their percentage of time in range if there's been a big change. And then there's the not meeting goals. So if they're not meeting 70% time in range, then they're in the next. So roughly we all have, it can vary, but we usually have around 20 messages or so for each week that we need to send out. Some of them are more. This is the workflow we came up with. So on the one side is where we used to, so patient was diagnosed, they did their outpatient teach. For most of our patients, we do outpatient teach. Within 30 days, they were started on a CGM. And so when we do the outpatient teach, we set up all the appointments now for them. We introduce 4 Ts. If they're interested, we send out a message to our research team so that they can connect with them to consent. And they set up an iPod for the kids who do not have access to a phone. And then we set up those appointments within 30 days, most of them within a week to 2 weeks after diagnosis. We have a handout that they get when we start the continuous glucose monitor, and then when they come back for the telehealth, or when we connect with them for the telehealth follow-up, we have another handout that reviews things. So we go over all of those things. And then after that, they come back to see the endocrinologist, usually about a month after that CGM start and follow-up appointments. And so we've been able to develop this workflow together as a team and tweak it as we need and make changes as we need. When we surveyed the CDCES team, we had 90% of the CDCESs respond. 3 that felt the process of starting the CGM in all patients with new onset type 1 diabetes within the first week was a burden. But 44% felt that the weekly CGMs added to our workload, and certainly they do. However, all of us felt not, the whole 100% of us that responded felt like it was worth the work. That the benefit that the kids got out of it, seeing the drop in hemoglobin A1Cs, seeing the families so appreciative. Most of our families in our pilot project and in our phase 1 have opted to continue. And so when they opt to continue, they get monthly reviews, not weekly reviews. So the benefit has outweighed the burden that we have all felt put on our workload. So in conclusion, we all want to continue this program, and we all feel like it was important. So 4 Ts stands for, I'm going to forget all of them: teamwork, tight control, technology. We always throw in tacos because we can never remember all 4. We always forget one of them, but teamwork is targets. Thank you. Thank you, Mark. Teamwork is really what got this whole program going. So we had a team of students from Stanford who created the TIDE tool for us. We had the physicians who were supporting all of this. We had the team of CDCESs that were making changes. We had the nurse practitioners that were willing to jump in and help us out with the telehealth appointments. And we have the research team putting together iPods and helping us with our workflow and fitting in the consents either before or after the CGM start, whenever is best for us. So the teamwork has really made this project successful. And we as a CES team really felt like our voices were heard and are continuing to be heard, so that we had input into this program. Does anybody have any questions?
Oh, sorry, we're gonna sorry for the technical issues. We're gonna hold the questions for Janine until perhaps after, if Janine doesn't mind staying
I don't
afterwards.
mind.
But just for the interest of time, we're gonna move on to Caitlin, who will talk about the nuances of socioeconomic status and health insurance associations with the hemoglobin A1C in adults with type 1 diabetes. For our chat, if you have any questions for Janine as well, if you could put that in the chat. Thank you.
Awesome. So my name's Caitlin. Caitlin Kelly. I'm a research scientist at the T1D exchange at the research outcomes and registry portion of our organization. And so I'm going to be talking to you today a little bit about something a little bit different than the other presentations we've done. We didn't start a big program. We did some psychosocial research, and we looked into kind of the nuances of socioeconomic status and how health insurance relates to A1C in a large sample of adults with T1D. So, as I'm sure everyone is familiar with, lower socioeconomic status is associated with higher A1C in adults with T1D. And these markers can include a lot of different things. Some of them can be individual markers like personal income or educational attainment, which are the probably the ones that people are most familiar with. We could also include insurance type in there, which is one that is related to socioeconomic status, but not necessarily the same thing. So your insurance type is going to be associated with your income, your job opportunities that you have. But past research in examining socioeconomic factors has really looked at these either in isolation, so taking a few of these, either personal income or education, or combining many of them into a single score. Which is really useful, but doesn't tell us which factors may be more important than others. There's also been limited distinction between income-based insurance, such as Medicaid, and age-based insurance, like Medicare, in some of these other past studies. And we know that individual markers of lower SES occur in a broader social context, and there may be community markers that also contribute to personal health outcomes based on past research. So our goals for the current study were to figure out in our large sample what factors were associated with A1C after controlling for the others. So this is examining concurrent relationships of demographics, diabetes characteristics like technology use, residential characteristics like income of your county and whether if you live in a populated or less populated area, and insurance, and see how all of those associated with HbA1c. And then we had a secondary aim there was to understand whether insurance type, specifically Medicaid, whether that can change the relationship between community level income and A1C. So our participants in this sample were adults who completed a baseline survey of the T1D Exchange online registry survey, and just over 9,000 of them. We included race, ethnicity, gender, age as our demographics. Diabetes technology included CGM use and pump use. Our individual markers at SES were income and education. We also had participants' residential area via their zip codes. So we were able to get median county level income, which we put into a mean variable, and residential area characteristics, which were metro versus non-metro, which I'll define a little bit more in the next page, and also health insurance type. So just a little caveat here that the T1D Exchange Registry participants are predominantly higher socioeconomic status, predominantly non-Hispanic white, and they are diabetes tech users. But there is a lot of there is some variability in insurance, residential area, and income. So you can see here in the first top part of the table, our A1C is of our adults is about 7.3%. Most of our participants are using pumps and CGM. As far as our zip code characteristics, the county level median income is the one that I want to kind of make a note here. And it's about 77,000 median income in our sample. So if we take all of the zip code incomes together and we look at the mean of those, it's 7,000, a little more than $77,000 per year. And you can see here that we do mostly have our participants on private insurance. Private insurance here did include people who reported purchasing their insurance through the healthcare marketplace. But about 9% were on Medicaid and 9% were on Medicare as well. just under 2% had no health insurance. So we used hierarchical Lineker models to examine which of these factors in our that we were interested in were significantly associated with HbA1c. And we found most of them were, with the exception of ethnicity, had no relationship to A1c. Medicare also had no relationship to A1c, and our non-metro residents. So these are people who lived in more rural areas or had a population of less than 20,000. All of these variables had no relationship to A1c in our model, but the rest of them did. So we've got pump use, CGM use, age, income, and education, and the median county income were all related to lower A1c. So when these things were either used or higher, individuals had lower A1c. Conversely, when participants reported the gender as female, when they reported racial ethnicity, racial identity as anything other than white, if they had Medicaid insurance or no health insurance, they also reported higher HbA1c. So when many individual characteristics and some of these community factors, such as the median income, were uniquely related to A1c, it's really important here to consider the magnitude of effects. So the biggest markers of the biggest variables that had the most impact on HbA1c, not surprisingly, were diabetes tech use. So we've got CGM use and being related to a 0.6, almost 0.7% difference in A1c for those who use it. And for pump use, it's about half a point difference for those who use it. Having Medicaid or having no health insurance also had moderate associations with higher A1c. So for those who are on Medicaid, their HbA1c was about a 1/4 point higher. And for those with no health insurance, it's just under half a point higher. And we used a kind of a composite score for racial identity because our group sizes were pretty small. But even when you kind of group everybody together, that also had a moderate association with higher HbA1c. So identifying as either Asian, Black, or some other races was also associated with about a 1/4 of an increase in HbA1c. Unfortunately, again, because of group sizes, we were unable to look at specific characteristics here because our sample sizes range from anywhere from 0.1 to 4.5% of our overall sample. As far as community level aspects of SES, the one that we saw was significantly related was median county income. So when median county income was lower, there was higher A1c, but it's a small magnitude of effect there. And we had no association, again, with living in a less populated area and A1c. So looking at that kind of moderation association, we wanted to know if insurance status could change that community level income and A1c relationship. We found that it did. So if you're looking at the graph here, the two lines that I want you to pay attention to are the green one and the purple one there. Here we see a decreasing kind of steep slope. And that's showing that people who are on Medicaid and to some lesser extent, those without health insurance, when their median county income is lower than the average, their A1c is actually higher. And it's important to note that that is on the lower aspect versus the higher aspect. We actually have to get pretty high above the average higher income for it to show actually the opposite, like having a positive effect there. So the conclusion here is that those on Medicaid and potentially those with no insurance, though caveat there is that our no insurance group was pretty small, suggests that those on Medicaid may be more sensitive to county level income, which we're interpreting to mean, could be related to county level resources that are available here. So in addition to personal resources that people are bringing to the table, their own income, their own education, we do want to consider county level income as well in understanding of the disparate effects of health outcomes for adults with T1D. So some limitations to consider is that even though we had a large sample size, some of our group sizes were pretty small. We did have this definition of metro versus non-metro instead of the more typical urban versus rural. We defined this based on some population data. So if population was less than 20,000. Unfortunately, that kind of based on our zip code data and the resources that we had, we're not sure how many of those non-metro were truly rural versus just being small towns near a metro area. There was also limitations of cross-sectional design and sample generalizability. Our sample was higher SES overall, mostly non-Hispanic white. So we're not sure how these would extrapolate to more diverse samples, but we think there's some interesting promise and interesting findings here. So the conclusions here is that we, again, want to consider the magnitude of effects for these individual markers and these community markers. So in our sample, we found that CGM use, pump use, health insurance type, specifically Medicaid or no insurance, and race were all related to differences in A1C, which is really consistent with other research in health inequities, and which shows that these factors are often compounded as well. So typically when people are, for example, one recent study that came out of the T1D exchange, QI Collaborative, was looking at race and lack of technology use, and finding how those things kind of go together. So we're suggesting some future research to not only increase technology use, but to target some services to people who are on Medicaid or those who have no insurance, and to better understand the needs and barriers of people with color, may be especially impactful. As far as county level median income goes, we are hoping to suggest for future research to further explore these areas to help understand why these health inequities exist, and try to understand if we can increase our resources in those lower income areas. Okay. And I know we are at time, so I'm happy to stay over for questions if folks have questions.
Thank you, Caitlin. I was watching the zeros and hoping it wasn't going to close out you, but luckily we're still here. Any questions for Caitlin?
I have a question. What is the distance of your non-metro from a metro place? It makes a big difference.
The question was, what is a distance, the difference between the distance of no metro versus metro?
That's a good question. So we used data like publicly available from, I believe it was the CDC. They have different categorizations for the zip codes. So when it comes to population size, we included everything that was rural, either classed as rural by their classifications or non-metro by their classifications. Unfortunately, it doesn't give us the exact distance from how far that is from the city. So I agree that's definitely a limitation, something that we're going to hopefully look into at a later date, and look into whether we can get a little bit more finesse out of those findings.
Any other questions for Caitlin? Thank you, Caitlin. Can Janine come back up to your questions?
We had the same question.
What was your same question?
How many nurse practitioners do you have?
We have we had two nurse practitioners at the time. Now we're down to, well, let me see, wait, one left after having a baby, and then we hired another one, but she hasn't started doing the telehealth. So it's been basically the burden of the telehealth has fallen on one nurse practitioner. And then we as the CDCES team have also picked up some of those telehealth follow-up appointments.
A specific date in the clinic, because this will add to this nurse practitioner scheduling capability.
Yeah, so when we were down to one, we did Tuesday mornings. And she had open from 8 till 11:30 for appointments, and they were 45-minute appointments. Yes.
Question. So if the other centers that don't have the same resources would like to also do something like that, how do you see, or even in your center, how do you move forward, like the sustainability of this intervention? How can you continue to do that?
Yeah, that's a good question. So I think that to make it sustainable, what we've decided as a team is one, we've been sort of short-staffed because we've had several going out on maternity leave and surgeries and such. So what we have asked for is, once we're back up to a full team, is having time carved out of each week for us to do our reviews. And roughly it would take 2 to 3 hours to do those reviews. So you have to be able to give your team enough time. I mean, it's really hard to do the reviews between seeing patients in clinic. So we need some admin time to be able to do our reviews. And we have now changed it. So in phase 2, we are only doing weekly reviews for the first 3 months. And that's based on looking at how often we were sending reviews on phase 1. So phase 2, we're doing weekly reviews for the first 3 months, and then they go into monthly reviews after that. And our research team is who keeps track of who is monthly and who is weekly for us, so that when we pull up my section of TIDE, it has just all the kids I have to review that week. And it'll say on there's a column that says if they're a monthly or a weekly review, but I get all the ones that are there for monthly. I don't have to worry that it was week 1 or week 2 or week 3 or week 4. Basically, it's every 4 weeks. It's not exactly every month. So,
so the intervention is mostly in the beginning, right? When you start the patients and then you do these weekly reviews. Now, I don't know that they published, you mentioned that you published some papers, right, about this. So I guess you probably had an intervention, a group of the part of the intervention, a group was the control, and at some point, it's an improvement, right? So was this sustained over time? So let's say you do the intervention for the first 3 months, and then you just follow up the patient. And what happened at 6 months or 1 year? Do the two groups are basically the same? So this early intervention is sustained over time, or you need to do repeated intervention on a monthly basis or bi-monthly basis?
that's a really good question. So what we did is we took our control group as what our hemoglobin A1Cs were before we started all of this. So nobody gets put into a control group. Every single one of our new onsets gets offered a continuous glucose monitor at new onset. And every single one of them gets offered the 4Ts program. And if they consent, they get the reviews for that first year, and then they can reconsent to continue. So we don't have a control group while we're doing this intervention. We just did, yes, prospective. Thank you. Yes.
So question, so as an adult endocrinologist, I'm sort of thinking about how can we translate this on our end. And I guess my question is, are you thinking of doing a cost benefit analysis of this? Because obviously work and factors like that matter, but I'm just thinking about, my goodness, this is a lot of work. And if you can prove improved outcomes, that's obviously, you can bill for the video visits, you can bill on the monthly for the CGM analysis. So at least you gain some revenue that way. But have you thought about that at all, or what are you doing?
Yeah, Dr. Moz is exploring that. I'm not part of that piece of it, but Dr. Moz is exploring that because we have seen such a huge drop in our hemoglobin A1Cs. And we started with, it would be harder as adults, I think, but we started with not the kids who had been diagnosed for a long time. We started with the new onsets. So we then opened up a kind of a piece of this we call our TIPS program. And it's for our kids who are on public insurance, that were struggling to meet the public insurance requirements to get a continuous glucose monitor. We got grant money through Dr. Prahalad, where we can provide them with a month or 2 months of supplies. So we can say to the public insurance, look, they're monitoring their blood sugar, and then we can get their CGM approved. So those are the kids who have had diabetes for longer, but otherwise in the public insurance realm, the private insurance realm, we were not able to bring in the kids who have had it, but moving forward, we're just continuing to offer it for our new onsets. So we've been doing this since 2019 now, I think is when we started our pilot. So we've been doing it for quite a while, and we have quite a few kids.
What percentage do you feel that consent to it in sustain it?
Oh, I wish I had those exact numbers, but it's something like, we've had very, very few decline it. I could probably name you the 10 kids over the last 3 years that the families declined it for various reasons, but very few kids have declined it, and almost everybody has continued after their first year and said, oh, yes, we want this. We still want our CDE to send us messages. Those exact numbers, Dr. Prahalad could get them for you if you want. Anything else? Thank you very much.
Thank you, everyone, for your patience with all the technical difficulties. Looks like the room will actually close at about 18 seconds. And it looks like we'll have some lunch. Thank you all.
Thank you.
Thank you.